so that we make evident the areas that we are not supposed to inject, which may worsen with the products displayed at this level. Retract the skin, pretest the degree of difficulty, and mark point number 1, 2, 3, 4, 5, 6, 7, and 8. Stretch out and proceed with the injection in point number 1. Don't forget to aspirate, perpendicular down to the bone. A total amount of 0.1 is injected. Massage. Proceed to point number 2. Aspirate. From 0.2, from 0.3 total volume. In this patient, I skipped point 3 and proceeded directly to point 4, changing to Ultra Plus in the nasolabial fold. Skipped point number 5 and went back to Voluma in the pre-gel sulcus. Now, point 7, bolus in the subcutaneous, clean, and we evaluate that there is already improvement at the marionette lines in this patient. The same is carried out on the left side. When we reevaluate the no-go area, we may notice now, after the 8-point lift, that the saggy skin is minimal. Mark the retruded chin. Pretest with a cotton bud. Entry point with a 25 gauge needle. And use Voluma with a 25 gauge cannula stretch the skin and direct to the area of volume loss. Proceed with fanning technique or retrograde and anterograde, and display the product in multiple layers so that we can give support to the more superficial areas around the perioral. We may also proceed and put the cannula in the chin, which would be point number 9. Massage, remove the markings, and evaluate the difference between the left side that was treated and the right side. We see that the oral commissure has lifted on the right and also more projected when compared to the left one. Another entry point and the change to Juvederm Ultra Plus. Getting the product through a cannula in the body of the lower lip, we proceed with the filling and replacing volume. Retrograde, check and reinforce the mucosa at the oral commissure. And again, a more lifted and correction at the oral commissure and marionette line complex is obtained. Do the very same on the left side. Start by marking the no-go area. Inject volume with the 25 gauge cannula. Retrograde, anterograde to compensate the volume loss and the retruded lower maxilla. By replacing volume at this level, we get a better anterior projection. Change to Juvederm Ultra Plus, because now we are heading to the lower lip. The importance of this strategy is to strengthen the modulus area so that there is an improvement and upward lifting of the oral commissure.
To be very, very satisfying. The first technique is to mark out the cheek. And if you make a little line that runs from the top of the ear through to the bottom of the nose, and then take a second line that runs from the lateral iris vertically downwards, where those two lines cross is nearly always close to the central point of where the center of the cheek filler should be. And you can confirm this by just gently putting your thumb on the cheek and lifting. And you can see that you want the filler tip, or that you want the tip of the needle that's injecting the filler to put the majority of the filler, about 3/4, right at that point, and then a little bit less laterally and a little bit less still further laterally. So in order to be able to fill those 3 areas from one injection point, the injection point needs to be in a position to fan such that the tip of the needle can reach those 3 points safely. The same position is marked on the other side, and I always get my patients to look in the mirror and agree with me that this is the position that they would like their cheeks to be enhanced. I think this is a very important step. What's surprising is the consistency of this point. Obviously, you don't normally draw in all these extra bits, but with a dry wipe marker, you can put them in when you first start using cheek filler, and then you can wipe them off simply with a damp cloth. Here, for the stage of the injection, I've wiped off the other marks. So checking where I want the tip of the filler to be, I tuck in, and this is a deep injection. Okay? So you slide in gently and then sit and wait, and do not inject at this point. If you see any evidence of bruise starting to form, then you may have hit a vessel. However, if there's no evidence of any bleeding, then slowly start to inject, and you'll see the cheek slowly start to lift. This injection is quite tender, And it's important to let your patients know that they will feel the expansion pressure. In terms of hierarchy of pain, I think this injection is actually a little bit more painful than tear trough filler and more painful than nasolabial filler, but slightly less painful than filling the lips. Currently I use local anaesthetic for the lips, but mostly don't use any local anaesthetic in any other position unless my patients specifically request it. So roughly half this 1 ml syringe has now been injected at this first point, and I need to inject a little bit more, and then it'll swing round and deliver the next 2.5 mils to the middle point, and then the last 1.5 mils to the last. By pulling backwards and fanning round, you should be able to do all this through one injection site and consequently minimise your risk of bruising your patient. You can see the cheek now is starting to realise some definition. As you fan round, I think it can be a little tender. And there you go, there was a nice little ow. And I think for fairness I haven't edited that out. And you can see the tip of the needle fans round and the last little bit of filler is injected. As a general rule, to get any visible effect you'll need at least 1 mil on each side, and to get a more striking effect 2 mils each side. I personally like to start with 1 mil and then see what my patients think, and the immediacy of fillers of course means that the patients can say whether they want more. This massaging and moulding is a very satisfying part as well as the cheek filler.
Hi, I'm Dr. Joe, and I am to LoveThatFace.com. When it comes to filling the cheeks or the mid-face, every patient is different, and there's no one way to treat everybody, and every filler is a little bit different. We're going to show you one of the techniques we commonly use, especially on younger patients, and we're going to use Juvederm Voluma. So there's a lot of ways to inject the cheeks, and one of the important things is the diagnosis, because every patient is different. People that say that there's only one way to inject the cheeks, or that if you draw one intersecting line, that's not true. Everybody has different anatomy and everybody needs different augmentation. So this patient already has pretty good cheek augmentation. Now this is Juvederm Voluma, and we have intersecting rings, kind of like the Olympic rings, and these are the areas, the infraorbital, kind of the submalar, and the lateral malar regions that I like to augment. And if you remember, Voluma is FDA approved only and specifically for cheek augmentation. This is not a subcutaneous filler. It's meant for deeper injection, and it just flows very nicely, and I think you can see that cheek elevating as we inject this. And then once I inject this, I like to massage it, and let's wipe that off. And it just doesn't take, I mean, that's a 1 minute cheek augmentation right there, and that just looks very nice. So again, on young people that already have beautiful cheeks like this, it doesn't take very much to augment. And you just want to blend it, and I think the middle circle is on the, wipe that off, and then let's wipe the dark off. The middle circle on the average person is really where you want your augmentation. Put some more on there so we can massage it. All right, let's blot this. And that's a nice, really nice augmented cheek and that's just with one syringe of Juvederm Voluma.
In the temple region, you have the superficial temporal artery that's coming up, and it gives off a branch over here called the frontal ramus. That's the one that you can feel your pulse in your temple. And when it comes across, it's going to avoid the supraorbital, and it actually likes to join up to the supratrochlear. But that's a highway to go right this way into the eye, and there have been 4 reported cases of blindness here in the US. 2 are temporary, 2 have some permanent loss because they hit that vessel. 1 centimeter up the temporal fusion line. You feel for the temporal fusion line. You go 1 centimeter up. You come 1 centimeter back following the orbital rim. This is your sweet spot. With that injection, you go right down onto bone. You put your finger over it to make sure there's no pulse because you would prefer not to skewer the artery if you could avoid it, but I've done it. And you'll see the product flow here and stop because it's fused. You'll see the product flow down to the orbital rim and stop because it's fused. And then the only place it can go, because I'm not allowing it to go here, you'll see it push against my finger, I won't let it, is it will come down this way right into the hollow of where I want it. I will not stick a needle under the skin over here. This is very dangerous.
Looking for different results. And basically, we can divide our mid-phase treatment into 3 different categories. We can make rejuvenation, enhancement, or remodeling. We will talk a little bit more about that later on. And this is a young patient, and she's looking for an enhancement of her cheekbones, not only rejuvenation of her midface, and she wants that sharpness, so this is a reason why I would like to choose Restylane Perlane. So let's have a look at our patient's midface and the different anatomical landmarks, because they can very easily be defined. So by lifting up the midface, we define the medial malar fat pad. Behind this, we find the presygmatical space. This is a very good area to use for augmentation. Medially, we have the nasolabial fat pad. Superiorly, we find the teardrop ligament, dividing into the upper and lower orbicularis retaining ligament, and then we have the buccal maxillary ligament, true and false, dividing the nasolabial and malar fat pad. So this is the basics of the midface anatomy. We can choose different entry points, laterally, most common in Europe, medially, Asian, and then sharp needle perpendicular into the area. They all have their pros and cons, and I think that there are many ways to roam, so of course different techniques can be used to achieve as good results. Then the $1 million question, where should we put the volume? Well, if we use a morphological approach by drawing up the malar fat pad, we know that if we just stay within that presygmatical space, we will rejuvenate. But we can also enhance some area by adding more volume, for example, laterally, to enhance it, or we can actually remodel the midface. So different approaches, and we put volume in different ways, not only calculating just one spot to show it. I also would like to point out this very nice paper published by Dr. Wong, which showed us the presygmatical space which we've been using for many years. We also need to take in consideration the retaining ligaments, and I showed you the buccal maxillary ligament dividing the 2 fat pads of the patient, and this we need to respect. So for this patient, it's an enhancement. She wants to have higher cheeks. She's a Caucasian, and we could talk for a long time on different ethnical and cultural wishes. But here it's basically a more lateral approach. We can do sharp needle, or we could have a lateral approach with our patient, entry point lateral from the malar fat pad, or medial, as is more common in Asia. From the medial approach, we can easily reach the teardrop, we can reach the whole presygmatical space, and honestly, they all have their pros and cons. I always draw my patients sitting up with full gravity, since gravity changes the face. This is a young patient. We're going for an enhancement. I draw both sides to find the similarity. Always clean not only the entry point but the surrounding area, working with a microcannula. We have a lateral approach, lifting up that malar fat pad, and very easily coax yourself into the presygmatical space. And finding that you can do with a microcannula, as it's blunt, you can define anatomy with it. In the presygmatical space, the cannula is dorsal of the malar fat pad and it runs freely. This is the area where we want to add volume. So if we look at this, it's very little resistance, so then we know where we are located. The gel contains lidocaine, so it's not painful at all for the patient. If I go more superficial in the fat pad, I will have a high resistance. And as you can see, the filler will move with the smile if I do injection in this area, just as it did for Putin. So this is how we create artificial results, by adding filler in the wrong anatomical layers. So let's look at the third indication, sharp needle. Is sharp needle injection safe? This is a question that we need to ask ourselves. We know more and more about the anatomy of the face, but we also know more and more of the big variation of anatomy between different patients. This paper came from a Korean team, and they looked at 35 cadavers and at the course of the branching patterns of the facial artery and how it runs close to the nasolabial fold and nasojugal grove. What the group showed us is that basically in 77% of the cases, the artery crosses or runs medially of the nasolabial fold, which means a high risk for sharp needle injection. Only in 23% of the cases, it runs laterally. So of course, with more and more knowledge of the big variations and that we don't know what we really can expect the artery to be located, it's definitely more and more important to understand the importance of the use of microcannula. So what areas are safe to inject? We have blood vessels basically running all the way down from the DAO with the facial artery, dividing to the inferior labial artery, up to the superior labial artery, up to the angular artery, and sometimes even a connection up to the infraorbital artery. When looking at the anatomy, we can also see that many of the arteries are interconnected, which actually gives us a risk of retrograde migration and a disturbance of the optical artery, meaning blindness. So many doctors around the world, they think that they might be safe from intravascular injections just due to aspiration. In my opinion, this gives us false security. So let's have a look at aspiration of some Coca-Cola. Coca-Cola definitely has a lower viscosity in blood and should be easier to aspirate than an intravascular position. So let's start with the Prime 29 gauge ultra thin wool needle. This is normal Restylane. The 29 gauge has the inside of a 27 gauge, and this gives us a false negative result when we have gel in the needle. Of course, it's more difficult to aspirate. This is a situation you have if you have already done an injection with that needle and syringe. So let's try a non-primed, meaning there is no gel in the needle. Still, due to the thinness of the needle, it's false negative. If we go up to a 23 gauge, we prime it, still it's a false negative result. The only way to be safe is to use a non-primed 23 gauge needle, meaning no gel in the needle, and we can get aspiration easily. So don't think that you're safe just because you aspirate. So sometimes we see sharp needle injections like this, and basically this might be dangerous. If we are lateral from the mid-pupil line and we're on the bone, there is basically no blood vessels there. But if we come more medially, it becomes also more dangerous. We need to know where foramen infraorbitale is located in the mid-pupil line and about 2 centimeters below the rim. So this is definitely a danger zone. If we go medial from this, I would say that this is a no-go zone. We should not do any sharp needle injections medial from the mid-pupil line, and there's no reason to do it laterally also, since we can do very safe and predictable injections with our microcannulas. So I suggest we avoid sharp needle injections in the mid-phases of our patients. We should try to use microcannulas. They give us an anatomical approach. She had 1 cc of Perlane on her right side there, and with a smooth, nice lifting effect to create a better definition. So before and immediately after, she had her cheeks augmented by 1 cc of Perlane on each side, but to maintain balance, we also added about 1 cc of Perlane in her chin. It's all about those areas interacting with each other, and we cannot only augment cheeks because too much, and then the patient will get out of balance and lose the harmony of her face.